Hi, everyone, and welcome to our second seminar series episode. We're so thankful that you've all tuned in today. To kick it off, we're going to do a quick introductions of ourselves. My name is Elizabeth Ashford. I graduated from Harvard in 2019 with a degree in psychology, and I'm currently working for RED, which is a nonprofit focused on helping those with HIV and AIDS.
Hello, everybody, and thanks for joining this call. My name is Andrew Siawa-Zamoa, and I graduated from Yale in 2019 with a degree in applied mathematics. I'm currently pursuing an MPhil in epidemiology at the University of Cambridge, where my research has been focused on chronic disease, especially in underserved and high-risk populations. Really excited to be here today.
Hi everyone, I'm Ashriana Rudran. As Andrew mentioned, I'm currently a master's student at the University of Cambridge studying public health. Last year I graduated from Harvard with a degree in economics and global health with Elizabeth. And most of my work is on sexual violence prevention against children in Kisumu in Kenya. And so being very passionate about violence prevention and studying public health during a pandemic, I think it was really interesting to see that the majority of public health advice was to stay at home. And that was kind of disappointing for me because when in reality, lots of people staying at home could lead to potentially very dangerous situations and also poor health outcomes. And so we started the COVID-19 task force on domestic violence to be able to bring light and attention to this issue and support organizations and advocates of survivors.
For those who tuned in last week, you know our goals are threefold: the investigation of data on domestic violence, the education of the public on these issues and how to get involved, as well as advocacy on behalf of survivors. The seminar series, is just one of our education efforts. To learn more about us, follow us on Instagram at COVID-19_taskforce-DV. Search for our Facebook, search at StopDVCovid-19, or come to our website at www.covid19taskforcedv.org.
Awesome. Thank you, Andrew. And now I'd like to introduce our guests. Today we have Ms. Ruth Glenn, Dr. Thomas Burke, and Professor David Hoffman. Ms. Ruth Glenn is the CEO and president of the National Coalition Against Domestic Violence. Prior to this time, she spent almost 3 decades working in the human services at the Colorado Department, serving as the director of the Domestic Violence Program for 9 years. Dr. Thomas Burke is the chief of the Division of Global Health and Human Rights at the Department of Emergency Medicine. This division focuses on those who are most at risk and aims to help through education, resource, and providing services. Dr. Burke is also an associate professor at the Harvard Medical School for Emergency Medicine, and he teaches as a course at the Harvard Summer Program on innovative technology for healthcare. And finally, Professor David Hoffman currently teaches the practice of cybersecurity policy at the Duke Stanford School of Public Policy. He's involved with several boards, including the Civil Liberties and Privacy Panel for the U.S. National Security Agency. And he has previously served at the Department of Homeland Security, Data Privacy and Integrity Advisory Committee, as well as the Board of Directors for the National Security Alliance. Thank you all for your time, and we're so excited to have you here today.
Thank you.
Yeah, so as Elizabeth mentioned, we have a variety of expertise and experience in our guests today, and we're really excited to be able to foster this interdisciplinary conversation. And so I wanted to start off the conversation by asking you, Ms. Glenn, given your immense dedication and experience supporting survivors, what are the unique challenges for those who experience violence at home during the times of lockdown?
Yeah, it's very concerning. And the question that I've gotten most frequently is, will we see an uptick in domestic violence because of stay-at-home orders? And I say absolutely. We will, we have already. No surprise to anyone. And I think it matters what community you're in, all of those things. Most concerning for me is those that aren't reporting because they don't feel safe reporting. And I truly believe that in May and June, if we are at a place where we can move out of the crisis of COVID, right, begin to relax how we need to address it, let alone how we might address it, I believe we're going to see a larger uptick. The other thing that really concerns me is the intensity in the home right now. I think we will see an increase in incidents, but I think the proximity and the whole idea that two people may children. They don't have a way to get out. They may no longer have the respite of going to work because they may not be essential or they've lost their jobs. The intensity by which survivors in the home are probably enduring abuse is something that we will also need to keep in mind as we begin to figure out how we provide future services, because I really do believe we'll see an uptick of those that actually do report once we are in a state of being able to relax some of the regulations that we have right now.
Sure. Thank you for that. And Professor Hoffman, could you perhaps speak about the challenges that survivors may face in trying to access technology during COVID-19?
Sure. I think the work that we've been doing at Duke is part of a larger cyber policy initiative where we look at the issues both where technology contributes to the impact on individuals in a way that creates risk for them, but then also the roles that technology can play in helping to increase benefits for people's lives. And we think that both of those paths really are present in the current situation. The inability for people to be outside the home and to use things other than the technologies that are provided in the home, to be able to either talk with people who provide them with support when they're going through an abusive situation and are trapped with their abuser, or to actually be able to communicate and to be able to determine how they could actually go find resources to be able to escape their situation in their home, is something that we've been interested in trying to explore. Is there outreach that we can do, and are there tools that we could make available to folks? We're particularly interested in the increased risks potentially from spyware and stalkerware that are even more easily loaded onto people's devices and tracked when people are confined within one part of the home. And then I'm also particularly interested and have testified to Congress on the impact of data brokers on this situation, and the data brokers tracking victims of domestic violence and potentially then being able to supplement the spyware and stalkerware with providing other tools for attackers to be able to understand what their victims are doing with the use of technology. So we're trying to address each of those issues and determine some very practical public policy solutions to go address them.
Mm-hmm.
So just to do a little bit of synthesis here for those two, I think, really eye-opening responses, it would seem that there is an expectation that there is an increase in these cases and incidents, but there is the worry that perhaps reporting has gone down due to the stay-at-home orders. And Professor Hoffman has brought up a couple of ways in which technology could potentially be used to create a new contact point, right? One where maybe previously, pre-COVID, there were other opportunities to interact in person, but without those, we're going to need to expand our opportunities for contact and reporting so that survivors can potentially move past the situations that they're in. This is kind of an interesting thing for me, and I want to actually bring Dr. Burke into this as someone who has experience on the medical side of things and the emergency medicine side of things. Even though this is an incredibly stressful time for our emergency healthcare workers, are there opportunities there to create an additional contact point? Can DV-related resources be shared there? Can screening questions be asked? Are there ways in which primary care providers can maybe leverage telemedicine to ask some questions or to learn more about their patients? Testing centers? Just interested to see what you think.
Andrew, thank you for having me. And this is a great question. And in fact, at Massachusetts General Hospital and in our Boston hospitals, we've actually increased our sensitivity around this very topic and have injected a few questions into every patient we see. However, I echo my two other colleagues on this call, and in their description that society currently has so many fewer Venn diagram overlaps of our human connectivity and connection. So in many, many ways, we're being isolated from those, those safety systems that exist in our lives. Those from elderly children to there are many different forms that vulnerable populations, um, you know, they look. It's not just a classic, or if there's such a thing as classic, that's the wrong word, I'm sure, but it's not just domestic violence in the interpersonal relationship, but it may be now the elderly, just people are having such significant constraints in terms of now their space that they're sharing, and now the lack of connectivity with other people they would normally connect with, and then the safety that comes with the socialization that occurs at all ages and in all in all different domains of our public. So yes, I think we in healthcare need to be more sensitive, and I know we are here in Boston, at least in the hospitals, but I think, as you rightfully pointed out at the beginning, that providers on the front lines are overwhelmed at the moment in many circumstances. And so, overwhelmed in many ways, overwhelmed with our own fear of our own safety. And it may not be numbers of patients, because actually the number of people seeking healthcare, I saw somebody the other day walking down the street with with an arm in a sling, one of my neighbors, and I did ask, both wearing masks, I said, what happened? And they said, well, typically I would go to the hospital, but I'm afraid to do so. So there was a lost opportunity for there to be, some kind of, of intervention if indeed there was an injury or a circumstance where somebody was at risk. It's one thing if they fall down their steps, but how did they fall down their steps? No one's there to ask that question. So I think there's an enormous unseen lack of safety with the stay home and be safe that you rightfully are pointing out. And I think that we do need to ask, and I think we do need to, everything's under such stress, we do need to figure out what kind of resources are there in our community that we can open up to make some buffer space, or if there is a violent situation where, and classically, a woman is the one that's usually a victim of violence, that there can be a safe place for this woman to go other than where she's been instructed and directed to go. But my biggest worry is the one that Ruth pointed out as well, is the voices that aren't heard, because it's very difficult for our voices to be heard now. I am, people are asking me, how are you doing? And I get up every morning, and most mornings I dress like a bug, going to the hospital, wearing all these contraptions. And then if not, I'm in solitary confinement and spending all this time, in virtual space. But so I feel a sense of isolation, and depression comes with it. Can't imagine what people in vulnerable circumstances feel like, and the output of that. So thank you for bringing us up. Such an important topic.
Yeah, thank you, Dr. Burke. I think for all of us, it's really important to see that this traditionally marginalized and often overlooked community is not, again, further neglected during this time. And I think it's really important for all of us to think about violence in the home in all contexts. Most of our work so far has been on intimate partner violence, but as you know, most of my work is on violence against children. And so I think thinking about child abuse as well as elderly abuse is also very important to us. And so we've been trying to deal with this thing of the difficulty in accessing at-risk individuals in order to support them during this time, and this idea of safety nets, where are all the contact points? When we're thinking about children, we've been trying to design a teacher toolkit to support teachers who are now accessing children over Zoom, and thinking about how they can support child survivors during this time as well. And so I guess something that we've been thinking about as we think about safety nets in general and how can we support them, what are certain policies that you would like to see? Maybe I can direct this at Ms. Glenn, coming from the National Coalition Against Domestic Violence. What are some concrete policy outcomes that you would like to see, perhaps from the federal government? I know that the NCADV put out the fourth letter to Congress, so I wonder if you can speak to certain policies that you'd like to see come from the fourth package.
Well, so first of all, thank you. And I'd like to make one other remark about those that are vulnerable enduring intimate partner violence and they're at home. Let's also not forget that it's not only that they may not be able to report or speak up, they're not allowed. So they may not have access to their phone now because they're further isolated and further controlled. They may not have access to their computer. So all of the tools that they may have used before to be able to maybe report or maybe escape or maybe use their safety plan that they may have had. That's why I'm very fearful of what we'll see in May. Because the tools that are normally used are now exacerbated. I'm going to take your phone, I'm going to take your keys, I'm going to take your checkbook. So they really are hostage. So policy-wise, so thank you for that moment to even add that on. But for policy-wise, one of the larger outcomes from a macro perspective is really the reauthorization of Violence Against Women Act. We know that COVID has stalled that a little bit, but the version that we would like to see has all of the enhancements that actually may help in a pandemic situation, correct? Such as making sure that we do comprehensive background checks on guns, that we have more housing available for those that might need emergency housing. All of those things are in that from a macro perspective, the Violence Against Women Act. And I could go on, but I won't bore you with that. I think the other thing that has been really concrete for us, and in fact, I just got off of another call in regards to that, so I apologize, I was a couple minutes late. But we need to figure out a way to be more responsive more quickly to those that are vulnerable, and understanding the special circumstances by which they have. Professor Burke or Dr. Burke talking about, the elderly. I'm very concerned about those who are infirmed in their homes because they've chosen not to go to hospice or rehab or nursing home or whatever those reasons are. They're still there, right? What are we doing as a larger community? And I know that a lot of local communities are being responsive. We've all seen the Twitter and Facebook posts of so-and-so driving over to make sure so-and-so has groceries. But what else are we doing? What are we doing in communities of color who are disproportionately impacted by this? And making sure that we take every bit of information that we have from what's happening right now and do a better job planning for the future. There's not a lot we can do to prevent what's happened. We can do a heck of a lot to prevent this from happening to the same degree and harmfully as it has now. For those that are enduring domestic violence, I also feel very strongly that the best folks that can help them are domestic violence advocates. And in this country, we're not doing enough to support advocates who do that on the ground work so that when the survivor finally feels safe that they can call, because they have to feel safe to do that, right? How are we supporting those advocates in positions or in situations such as COVID so they know how best to respond? You wouldn't believe the questions that we've gotten here about how do I advocate? How do I do tele-advocacy? How do I make sure that my bed spacing is enough that so-and-so is not going to be harmed? And how do we check for when somebody's coming in that they're not, and exposing me, my team, or other advocates or other residents? So let's take all of that information and figure out, not just for the IPV community and those that are vulnerable, but for everyone. As painful as this has been, and I can certainly identify with isolation. I'm an introvert. I thought this would be okay. It is not. But let's take all of that and as much data and information as we can get and figure out how we respond, because this will not be the last time something similar happens.
That's a really good point, I think, in thinking about how we can convert this current attention at this current time, how we can potentiate that to change so we don't see things like this ever again. right?
Right.
I mean, we can build things, we can put things in place that can prevent that. And
Right.
I liked how you brought up the specific Violence Against Women Act and how it's been bolstered in many ways to potentially alleviate some of these things. And no, it's really, really great to hear that.
Yeah.
I wanted to potentially ask a follow-up on that. You had talked about there are ways in which we can support advocates, right? That's something that our country needs to be better at doing. Is there a way for the average person to support, whether that's donations, whether that, I guess, like, what does that look like? What are the things people can walk away from this session today and go like, this is concretely what I'm gonna do to assist?
So there's always three actions that come to mind as far as taking action, right? Or three of them that come to mind, which is donate, donate, donate. Whether it's your local program, whether it's a program like ours, National Coalition Against Domestic Violence, our cash flow is always hurting, always. And particularly in a situation like this, we heard from a program that is someone donated an RV to them to be able to have 2 extra spaces. That's fantastic, right? So because because of the spacing that had to happen, they were running out of capacity in the actual shelter. So somebody donated an RV to them. We, as a national organization, we shored up advocates yesterday, opened up a webinar to help them feel resilient and inspired. We had a 500 capacity. We had 1,500 people sign up. So that tells you that there's a need to feel like we're doing something, and what does it take? Take action in your local community, and I don't mean just with the domestic violence program, although that's the first choice. Call your congressperson and say, look, I don't know if it's Violence Against Women Act, I don't know if it's a local community action that we can take, whether it's related to our 211 or 311 or whatever it is, but let's infuse and make sure that in all of these legislative, policy, regulatory avenues that we're talking about the vulnerable domestic violence population. And then, you know, I could go on, but I won't. And let's not forget, what are we doing to make sure to hold abusers accountable? Because abusers they're the recidivisms, right? They're the ones. So what are we doing to make sure that we're addressing this issue from a holistic place, whether it's funding, whether it's policy and legislative action? What is it that we're doing within our other community response teams to make sure that we're addressing it? So those are the three.
Thank you. And we've talked a lot about, you know, the at-risk or those who are kind of disproportionately affected. In terms of sort of data collection, is there a way we can improve on finding these people, you know, or finding data that, or technology that will help as we kind of collect and go forward and locate the areas that we need to be paying attention to the most?
Are you asking?
Yes, you or if anyone wants to answer.
So I'll remark really quickly, but then I would certainly open it up to my other colleagues. Tracking domestic violence is very challenging unless it's being reported to the police, right? Advocates probably have the most valuable and best information about domestic violence victims. But in order for a domestic violence victim to come forward, there has to be a level of confidentiality. So advocates cannot share what we might find as valuable data. You know, how so-and-so, is this her third time in reporting into shelters? You know, all of those kinds of information. But I don't think it's impossible. Going back to policy, my dream is, as in the work that I do, we do come up with some kind of universal reporting a piece from every jurisdiction, even if it's just from survivors reporting, not necessarily those that we can't have access to, because it'll help us eventually figure out how to get access to those other folks. So that's my initial thought about that, is that it's very difficult, and if somebody comes up with a way, let us know.
I think that's an interesting question. You know, how and do we need data? I think we do need data, and it was quite telling when Ashri and some of her colleagues started looking at what do we know about change in violence within societies in time of pandemic or in time of emergencies. And really most, well, we couldn't find anything other than some small observational type of data going back, gosh, how far was it? Almost 400 years. It was remarkable to see how far back they explored. So I think in order to really, convince policymakers and to make systemic change, we do need data. And now comes what Ruth just brought up is how do we actually get data? And so if access to points of where data might be captured now become difficult for, for those that have unfortunately become victims of violence, how do we actually know? How do we know what's out there? So what I gravitate towards is really population-based survey instruments and perhaps even more qualitative research across populations, because just as asking the question, are there more or less heart attacks during a time of a crisis? I can tell you that all the emergency departments in the United States are seeing maybe 10% of the heart attacks that we normally see. It doesn't mean that they're not occurring. It just means that they're not being seen and that they're at home and people are afraid to come in. I think we can translate that to something that is, I mean, that seems obvious in the heart attack realm, but people don't grab that as to domestic violence. But it's no question, if you don't have access to being able to get out of a situation, we're not going to capture that data, and it's going to be difficult to intervene. So I think we have to think about ways to really capture data, and I think it's very important. And I think there's some opportunities. Some of them might be in hindsight. Once this is gone, several months, we might actually be able to really take on some population-based data in some creative ways of exploring what has actually happened to people's experience during the time. And I just know amongst my own colleagues that are in fabulous marriages and otherwise, that the stress levels within relationships are all escalating. It makes sense. And so one can imagine if you're in a circumstance that is vulnerable, and there are relationships that are vulnerable, that those risks become much higher.
I'd like to echo a little about that public policy, particularly at the federal level, at its most basic concept is about the allocation of scarce resources and the allocation of money. And to do that effectively and to advocate for a particular source or a destination for that money, better data often wins the fight there. And so I actually think this is a place where we have challenges right now based on people being able to report, but this might be an area where technology really can help. And this is one of the things we're going to pursue at Duke, which is, are there tools that could be created that could be distributed out to all of the domestic violence shelters that would have a standardized format for data and standardized APIs that people might be able to go to people who could do research on that data in an automated way? I would want to give two examples of reasons why I think this is so critical right now. One, we have a tremendous amount of stimulus money being created by the federal government right now to take care of issues that are creating risk in society coming from COVID-19. The areas that are getting the greatest amount of that stimulus are the areas that can present a lot of data around the impact. It's clear that there is a tremendous impact on just the surge in volume for domestic violence shelters, but do we have the data to be able to present that there should be stimulus money going to provide extra resources for those shelters? Another thing, there's been a tremendous amount of activity over the past couple months. I'm assuming Dr. Burke is probably much more expert in this than I am, but I've been doing a bunch of work in publishing in the area of telehealth technology. We're encouraging everyone, instead of going into the doctor, to use technology to be able to communicate with your doctor and get medical services from home. Well, in a situation where you have an abuser in the home, that takes away yet another important mechanism where someone could get hurt. Have we done, there's been a tremendous amount of money identified to help implement telehealth in a way that takes care of underrepresented populations and people who are particularly at risk. But I've yet to hear of any money identified to understand and to take care of the consequences to victims of domestic violence from taking them out of their doctor's offices and forcing them to have those communications from their homes. These are things we really need more data for and more research for, and then advocacy for.
And I would add to that, thank you so much for bringing that, because it also adds to the elements around reproductive coercion, right? Because we know that that is absolutely a tactic. And if you're forced to be at home to talk to your doctor about the things that you either might be doing to make sure that the coercion is not happening, or that you need to address birth control or other types of issues, we know sexual assault plays a huge part in IPV. How are we addressing that within telehealth to make sure that it might be that you need to have an in-person visit with this person, and let's not promote telehealth for those that have already identified to you that they're enduring IPV. So thank you so much for that. It's a great point.
I also wanted to potentially pose a follow-up, and this might be primarily directed at Professor Hoffman, but I'd like for anyone else to add in if they have something to say here. But can we conceptualize ways in which potential survivors can report even if their technology is being supervised or controlled by their abuser? I think this is something that Ms. Glenn had mentioned earlier. If their technology gets confiscated or things like that. Are there ways in which people can report without it showing up in their search history, for example? Is it that we just lack tools in that area, or is it something that we can include in? I know quite a few primary care providers have apps where they share tools and data with their patients, usually in a different context, but can those be repurposed in a way that can prevent that kind of oversight from another person who may not want that information to get out there? I'm interested in that.
Well, I'll just take that very quickly to begin with, and then others can. I think we have not adequately addressed that right now, and there are several public policy decisions that have been made in the past that further frustrate that. So in many situations, particularly in the telehealth area, you would have been required in the past to do audio plus video as part of your visit, thus then making it even more complicated for somebody to be able to do something, versus where you might be able to use a chat application on your phone that wouldn't show up even if there was other software that was trying to access that because it's creating an encrypted channel. But I don't think we can expect that individuals are going to be able to figure that out on their own. So I actually think the biggest component of that is how do we get education to folks about what would be the safest mechanisms?
So thank you so much for that, because yes, if they don't have access, I don't know what we can do, access to that technology. Not long ago, a woman was in her college dorm. She was able to, she was sharing with her boyfriend. She was able to run to her closet, text me. You'd be amazed at how they find me, which I am just one more step. So I always feel really bad when they get to me, because I'm like, well, wait a minute, I need to get you to somebody else. But she texted me from the closet and she said, I will text you back at X, because he's watching my phone. He has control over my phone. I was able to, use it. I'm supposed to be in the restroom. I'm doing that. So I think we go back to basics when we're talking about somebody who's in real crisis, right? Which is a good old-fashioned safety plan that has nothing to do with technology. It's, I'm going to flash my porch light. If I flash it over the course of so many hours, or days, or minutes or hours, make sure you call somebody. If I hit the ceiling with my broom, please call the police. If, dear son, you're 6 years old, but if mommy tells you to run out the door and go over to Joe's house across the street, please do so, because Joe knows what to do in response. So when an abuser has access to those, there's really not a lot we can do. And I really appreciate bringing up spyware. It's becoming so prevalent that they're putting it on cars and phones and everything, and there's no getting out of that, and particularly if you don't know that it's there. So for those extreme situations where we know that the mechanisms by which an abuser can maintain control and diminish a survivor's independence, we just say resort back to a good old-fashioned safety plan, which is a keyword or a code, or you've been allowed to go to the grocery store, drop a note. You know, we've all seen the videos where somebody slips a note to the veterinarian or the pizza driver or whatever it is. And I really wish there was some other way, but I always want survivors to know that even if those things are taken away from them, they still have the ability to plan for their safety.
I just want to comment on that, I also think part of the education then is educating the people who might receive those notes.
That's right.
The pizza delivery folks, the folks at the grocery store, which might be one of the few areas where people might be going, to be able to spot the folks that really are looking for help.
Somebody asked the other day, what do we think about the DOT program? I don't know if you've all heard about this in France, where the pharmacy, I'm very concerned about that, because you're absolutely right. If I don't know how to respond to somebody who's given me a DOT that says I need help, are you saying call the police? What am I doing with this? And then how do I make sure you're safe? If you're going to stand there, if you're going to walk away, what does all of that mean? So on those instances, I agree with you 100%. But if I've had a relationship with my neighbor, they know what's going on, I've opened up to them, I want them to being a part of my safety plan, they would know how to respond. So that's what I mean by a grassroots sort of safety plan. I am not personally a fan of these other mechanisms by which we use. But if you're in crisis, absolutely slip a note to your veterinarian, because you're at the point now where it's like, okay, I need help and I don't know what else to do here. So
I have two thoughts I'd love to share. And the first one is just, somewhat related, but it's about, personal autonomy and control of one's body as a woman. And that is, my wife's a pediatrician, and I'll give an example, but this is undoubtedly spread countrywide, and a lot has been moved to telehealth, although the access is certainly much, much less than it's been. But I asked her just yesterday, I said, well, how are you having conversations with teenagers in particular around their sexual health? And she said, well, I just ask the parents to step outside of the room, or I ask whomever else is in the room, and that may be a partner, or maybe, and we can see that there's a distinct loss of privacy, a distinct loss of control of one's own sexual health. Now, there's something we can really do, and I anticipate, Andrew, Elizabeth, and Ashri, this is where you're going, but I think it's extremely important that we advocate and all of us take steps to connect with those in our lives that may be vulnerable, that may be isolated, which we all are isolated, but some much more so than others. Members of our family that may be disabled and don't have access, and are extremely vulnerable. And make sure that those Venn diagrams of society that have really been separated from one another, that we try to create some kind of overlap, because we're reaching out to each other in an extra special way. And, check in on our neighbors, call people we haven't called perhaps in a long time, write to them, email, check in. I think there's really opportunity for us to each of us, all of us, worldwide, to extend our arms and reach out to those around us. Be each other's safety nets as best as we're able.
I definitely want to echo how much I loved hearing that just from all three of our guests today. The need for us to really bring our social networks together, for us to all play a role in our communities to help out. I think earlier it was mentioned, it's one thing to educate survivors about how they can potentially have a plan and escape. It's another thing when maybe they try to reach out for help and the person they reached out to doesn't know how to react, right? And so I think some of the goals of our organization are educating not just survivors of potential resources and having a plan, things like that, but also turning people from a bystander situation where they don't really know what's going on. They don't know what these words or movements are. If someone asks them for help, they wouldn't know where to go to, turning them from a bystander into an ally where they can see the signs, they know how to react, they can be deployed. Because one of the things mentioned earlier between Professor Hoffman and Ms. Glenn about how sticky the technology situation is and how kind of relying on more community-based efforts might be more durable. What's also great about that approach is that it's more universal as well. It's more global. There are parts of the country, parts of the world that do not have the same access to technology. And so we can't just make it that we only have solutions for people who are in kind of these high income, high technology societies. It should be that they're democratized across the globe. And I think kind of thinking about the community and thinking about how the whole world is reacting to this kind of leads to my next question. I know, Dr. Burke, you have experience working globally, training doctors, working with healthcare professionals all across the planet. I guess perhaps I just want you to maybe speak to how medical professionals across the globe are trying to address or have addressed challenges of domestic violence within your experience, if you have experienced that.
Are you, Andrew, when you ask that, do you mean within the context of COVID-19 or do you mean in general?
I think a mixture of both. I know some of the ways in which healthcare professionals would be allies in this time will look similar in both, but I was wondering if that's something that globally people are thinking about and if they've found new solutions in that regard.
Yeah. Well, thanks for asking that because, we are fortunate, although, domestic violence is an ongoing pandemic worldwide, and there is no society that is free of it in any way, even though, when I was in the military, I once was told by a commanding general that we don't have domestic violence or child abuse in the military. But there is no society that's free of domestic violence, and interpersonal violence, sexual violence in children. But I think that outside of the 24 developed nations, or the classically described 24 developed nations, it's even a much more difficult time because the stresses that we're incurring, and there are many societies that actually undergo these stresses on a daily basis or in a much more frequent routine than what we're experiencing, for example, in the United States today or in Europe today, whether it be Ebola crisis, famine, whether it be ongoing, still there are parts of the world where HIV is at 40% with tuberculosis and chronic parasitemia, on and on. There are large stretches of the African continent where child malnutrition rates are in the 30% plus. So in those circumstances, the vulnerable often have no voice, and there is no safety net, and there is much, much more work to be done. And it's not that there's no comparison in terms of it's not a competition, but there's so much more work to be done, and there's so fewer resources. But I think at a time like this, those populations are even more vulnerable than our populations, because what fragile whisper of support that someone may have really becomes fractured. And so I worry just from COVID-19 across where I spend a lot of my life in the African continent. I worry dearly for where a country like Kenya has less than 40 intensive care unit beds for the many millions of people. I worry for India, which is now predicted to lose 38,000 lives in the next 3 weeks. And that's just the beginning. They've doubled each of the last 2 weeks. And many, many countries. And so every day we're watching our own task force, and we're worried so much about our own country, which I, of course, worry about. But this virus doesn't really know the borders of countries. It doesn't know the difference between this language or that language that the humans speak. It doesn't really know this side of the river, that side of the river. So we do have to pay attention as a human family more than ever before. I think this is amplifying the inequity on Earth, inequity in our own society for sure, but inequity on Earth even more so.
Thank you for that. And sort of looking ahead, when we're all released from lockdown and isolation, life won't necessarily be going back to normal for a really long time. And we're wondering, looking forward, if there are challenges that survivors might still face that are abnormal to something that would have happened prior to COVID-19. Like, for example, the economic situation will likely leave many much more vulnerable. So is there anything that we think we could maybe be aware of and help potentially plan for? And this is for anyone, if anyone has any thoughts.
I think that it's not a matter of if, of course, what you've said, but what will it be?
Right.
I think economics is absolutely going to impact those who have been able to get through this period, surviving and being safe. They will have endured an economic impact during this time that they're going to have to face. One of the things that it strikes me as you said that is that we also cannot forget that as much as economics is sometimes used as a tool to ensure control, it can also be the road to independence. So if I don't have it now, and now we're out of lockdown and I may have some freedom movement to be able to do something, now I don't have the money, or I don't have a job, or I don't have access to our finances. I think the other thing that will be interesting, and this is really personally my own theory. I'm a survivor myself, but so I speak from always thinking about what that means. I do think that our health field will see some different things, particularly for those who have identified that they had experienced IPV. They're just now able to get that freedom to be able to get what they think is medical assistance, or what they need is medical assistance and those kinds of things. So I think we're going to see, I think we're going to see more long-term effects of strangulation. Strangulation is a very powerful tool to maintain control of somebody you have proximity to. We know that there are effects of strangulation that last for a very long time. I think we will see more reporting or seeing of partners coming in with their children who have now also not only potentially been exposed, but also have fallen victim themselves. We have been subjected to victimization themselves, because we know that an abuser will frequently begin to abuse the children, even if the adult has been their primary target. So I think we're going to see some of those things that we've probably seen before, and maybe we hadn't thought much about it, but particularly around economics and particularly around health and well-being, I guarantee you we'll be seeing some different types of things that come out of that. That's my thought.
I wanted to give everyone else an opportunity to maybe contribute to that point if they wanted to, about the long-term effects, just before moving on.
Sure, I'm happy to. And the long-term effects of interpersonal violence, sexual violence, children or adults, are profound. And certainly as we isolate as families, then those that are exposed to it may have a much greater intense exposure.
Yep.
The length of time that the violence lasts before they're able to break free from it maybe longer. It may not be just a single event, which it usually isn't anyway, but it may just, as we've discussed already, it may be far fewer opportunities for the victim to break free. So I think that all that comes in. These are lifelong scars. In fact, I think we know that sexual violence and interpersonal violence actually then is carried on to the next generation. It's not even something that lasts for years, but it lasts for lifetime, and violence is passed on through generations, as is actually seen in studies. And not just that the habits of a perpetrator being violent, but those that receive or are subjects of violence, but the effects of violence, all of those are passed on. These are long-term scars and take a lot of healing. I think that, my goodness, there's so much to say about our health system that's become quite evident in this time. And one of them is how fractured our health system is. And I'll just say, I say this, and give away a fair amount of my own personal opinion here, but that our health system, right now, it's very clear that it was designed around a market and money making, and all the broken pieces between are now evident, instead of being focused around what does our human population need and what are the needs of the population. Let's construct it around that. So we've, in this country, have really chosen the former, and I'm hopeful that this may push us more towards what does our society need, and then right in there is that around safety, around what do we need for sexual health, what do we need for optimal societal health. Means those that are most disenfranchised and most vulnerable have access to health care. And this virus also tells us that we need to take care of those that are most vulnerable, just from a virus perspective, because if they're carrying it, they can carry it to those that are privileged and those that do have access. So so one silver lining, perhaps, in what we're seeing in some of the horrible statistics in terms of inequality, is that this inequality is hitting us right in the face. And I'm hopeful we'll have some significant structural changes that'll benefit those that are vulnerable in our society.
I would just add that I worry about the economic impacts. I worry also about the long-term psychological impacts of having lived in isolation, and just the fear of the virus and the impact on whether people really believe that they have hope for a better life. And I think that's something that needs to be reflected in public policy, that we are going to need to be able to identify resources to communicate to people that there are opportunities to get help. There are ways to get out of situations that are bad situations. And we need to recognize that the impact of this long period of time of being worried about contracting a virus and what could happen to someone or to your children, and to not react to that fear by entrenching, but to react by seeking out help and having hope for a better life. I do think we're going to have to commit resources to that.
Yeah, definitely. I think with this pandemic and with the lockdown measures, we have seen and expect, the rise in psychological distress, economic stress, the lack of support networks, and the increased isolation. And all these things are problems each on their own, but then also exacerbate all the domestic violence problems and violence in the homes, which have, as you all know, short and long-term consequences that we all worry about. And so I think, as you mentioned, Professor Hoffman, it's extremely important to think about how we can collect data to try and provide evidence for this problem in order to mobilize resources. And I think for all of us, it's important not only to mobilize resources now to support survivors and those in need, but also beyond the pandemic. And thank you all for joining us. And I think Andrew is going to wrap us up. I don't want to take up too much of your time, but I really have appreciated listening to all your perspectives. And I think we've learned a lot today.
just want to echo what Ashley just said. Thank you so much for everybody who came and joined us, and thank you also to our viewers who are listening in. I think we've collectively can take a lot away from this conversation. From Ms. Glenn's points on the danger of low reporting, the power of the Violence Against Women's Act, and the importance of donations and community engagement. Dr. Burke also had some really good thoughts on the global impact of this crisis and how it asymmetrically can affect folks like the elderly, those with weaker social networks, and then other societies may face different burdens. Perhaps also this will be an impetus for our society to pursue a different structure for our healthcare systems. And also Professor Hoffman's thoughts on the interesting intersections of cybersecurity and domestic violence, and how cyber policy has sometimes gotten in the way of technological reporting, and perhaps even the ways in which policy can do better in education. I speak for myself here, but I think I speak for all of us in that we have a better idea of the potential effects of this crisis, how we as a society really have to take responsibility and get involved. So kind of moving off that, I think thinking about community engagement, thinking about learning how you can be helpful to survivors, going on that journey from bystander to ally. The COVID-19 Task Force on Domestic Violence, we're here to help you through that path for all of our viewers. We host seminar series like these every Friday, but if you want to learn more or get involved, please follow us on our Instagram at COVID-19_taskforce-DV. Check out our Facebook page, search at Stop DV COVID-19, and check out our website at www.covid19taskforcedv.org. Thanks so much for tuning in, and we're going to sign off till next week. Thank you so much.
Thank you.
Thank you.
Very nice to meet you all.